That's when big transfers occur from that environment to the Good morning. Well, they have been the team and we'll give it a shot. We just think that we're going to go ahead. Do I have the title of the talk? Not with me. Good morning, everybody. We're ready to launch our 2018 Grand Rounds, and I think Dr. Sharkey is going to make a brief introduction. We've been talking about microphone issues for several months. When we ask questions, when the audience asks questions, please speak directly into the mic. Try not to do this because we'll lose you, okay? So I know that's hard to do. So if you can remember to just hold the mic right straight under your mouth, we'll do a lot better, okay? So with that, I will turn the microphone over.
Thank you, Jolene. It's interesting that of all the physicians we have, none of us can figure out how to use the microphone properly, so I appreciate the advice. I am really honored this morning to introduce our first Grand Rounds of 2018. The title is going to be the ideal preoperative evaluation of patients as it comes to testing, especially in the cardiovascular sphere. And we have three distinguished guests this morning. Mike Cummings is the co-leader of the Abbott Northwestern General Medical Associates, and Dave Ingham is also with that group and has been appointed as the Ambulatory Director of Information Services for General Medicine. And Alex Campbell we're still looking for his title. He's one of our partners and has been working on this project along with Mike and Dave since about 2010. Is that about right? 8 years. So this project that they're going to share with you is extremely exciting. I know bits and pieces about it. I can tell you how hard they've worked because to get this to the point where it is ready to be used has required extensive meetings with many disciplines in this community, including, I know, going to anesthesiology meetings at 6 a.m. in the morning at Mercy and United and on this campus. So not just here at Abbott Northwestern Hospital. They've interacted with us in cardiology and with vascular surgery to try and get this to a point where it makes sense and will be a positive improvement for our patients. So with that, Mike, you'll notice that they're all dressed in their customary blue, and I had to wear my blue blazer in honor of that. So Mike, please come up and join me on the stage.
Thank you, Scott. I do want to let the audience know that Scott's been a part of this process since the beginning, and he's just been a terrific mentor for the three of us. And when I think of a sort of a clinician, scientist, he's like the perfect one, a person who's able to be a practice medicine in a private practice setting and yet be a physician scientist. And he's just been a great mentor for us. So thank you so much, Scott.
Those of you who know me, I always have to open a talk with a philosophical quote, so you'll just have to indulge me for a second. But Jacques Barzun is perhaps the greatest historian of the 20th century, and he said, new ideas do not battle so much with ignorance as with solid knowledge. And one of his areas of expertise was culture, and particularly the influence of science on culture. And when he was a great admirer of the science, particularly the scientific method and all the great things that have come out of science. But he also knew that the history of science is a little more mixed than we want to admit, right? And that scientists in particular, and by extension physicians and intelligent people, we sometimes think we know more than we know, in the sense that we sometimes get beyond our skis and think that we always know the truth. And we'd like to make fun of people who we would call flat earthers and that type of such and say we know the science. But if we're honest, science changes. And so we need to have a little humility sometimes when we talk about some of these things that are coming up today. Dave? So why is this an important topic? Well, the truth is this topic came out of frustrations of the unnecessary testing you would see as a primary care physician. You get requests from different physicians to do all these tests before you're doing a preoperative evaluation. And from that frustration, we started to say, why are they telling us to do this? What is the evidence that says I need to get this hemoglobin or an INR or a PTT? It turns out we spend about $18 billion in this country on preoperative testing, of which about half of it is considered to be unnecessary with no clinical indication. So it's a big deal. So I just want to give you guys an idea of the challenge a primary care clinician faces when they're doing a pre-op. Okay? The first thing we need to consider is the patient's characteristics. Now that could be a 25-year-old with no medical history on no meds, right? But it could be an 82-year-old woman who has 13 things on her problem list and is on 15 different medications. In addition, we have to consider the procedure. Is this cataract? Is it a Whipple? Is it a total joint? What's the risk of that? In addition, we have to consider what's the bleeding associated with that procedure, which is a different question. Some procedures have high risk for bleeding, but they're not high risk procedures. And finally, what type of anesthetic is going to be used? Is it going to be general? Is it going to be general with the epidural? And that has completely different implications when it comes to anticoagulation holding. And finally, is it going to be a spinal? So you start to do the math on the probabilities, and you realize there's an unbelievable amount of permutations that are possible when you're doing a preoperative valve. But for the purposes of this audience, I want to focus on sort of the vascular issues that may arise when you're doing a preoperative evaluation. Well, the first question you're asked is, what is the cardiovascular risk of this patient who's going to have this specific procedure? And the question is, do you use a risk model? And if you are going to use a risk model, which one do you choose? Are you going to do cardiovascular testing? Does this person need an EKG? What's the information that supports an EKG? How about a stress test? How about an echo? So these are all potential questions we're supposed to address. How about antiplatelet therapy? If they've had heart disease and they're on aspirin, do we continue it or do we stop it? And if we stop it, when do we stop it? If they have a stent, what do we do? Do we continue both if they're on dual, or do we stop one? If they're on Plavix, do we stop? When do we stop it, if we're going to stop it? So there, you start to do the thing. It's like there's a lot of different permutations we're asked to consider. What's that patient's thromboembolic risk? Is there a formula for that? If so, which one do we choose? What's that patient's bleeding risk? And if they're on anticoagulation, do we interrupt it, or is this a procedure where you can continue it? And if you do interrupt it, when do you stop it? If they're on warfarin, when do you stop it? If they're on a direct oral anticoagulant, when do you stop it? You can see how that's kind of complex. Depends on which one and the renal function. And if you do interrupt it, when do you stop? If you do interrupt it, do you bridge or not? And how do you figure out whether you're going to bridge somebody or not? What goes into that? What formula do you use for that? And if you are going to bridge, how do you dose the enoxaparin? What formula do you use to estimate their kidney function? Do you use their actual body weight, their ideal body weight? These are the questions that really potentially come up. And then how do you pick the dose? There's actually a different formula for dosing enoxaparin. And finally, what's the hold time for it? And a lot goes into that. There's a different formula for that. If you want to do this right, you realize it's almost an impossible task. So what went into the design of this tool? Well, I'll be honest with you, Steve Jobs is what went into the design of this tool. He was sort of our guide. And he said that design is not just what it looks like and feels like. Design is how it works. And if you think about it, that was what his genius was. He was able to design an iPhone that everyone could use. And now we all use them. And that was sort of our philosophy that went into this tool 8 years ago. So we wanted this tool to be very simple. We wanted the physicians to be able to use it very quickly and it'd be a very intuitive tool. Our goal was not to build the perfect tool. Sometimes the perfect can be the enemy of the good. You build this perfect tool, it's cumbersome, and nobody uses it. Our goal was to have physicians use it. It was that simple. And Steve said, simple could be harder than complex. You have to work very hard to get your thinking clean, make it simple. And as Scott sort of alluded to, we've spent lots and lots of hours just refining it. And I can't tell you what iteration we're on now, but it's got to be at least like the 15th one. We wanted our tool to be based primarily on primary sources. We wanted to go beyond the guidelines. If you think about guidelines, they're really expert opinion most of the time. And anytime you take data and convert it into recommendations, it requires subjective judgments. And that's an important thing to remember. We also wanted it to be based in common sense, right? Sometimes these tools are designed by people doing practice medicine, and as a clinician, you guys know it, we get this stuff forced down us all the time, and nobody uses this stuff. So we wanted to reflect common sense. And heuristic wisdom also means our experience as clinicians. Is this something we think is important or not important? So I think we were really at an advantage that we were designing this tool organically out of our own frustrations as opposed from up high. And finally, we wanted our recommendations to be contextual. And what do I mean by that? I mean it depends, it depends, it depends. When the evidence was really clear, we wanted to be very prescriptive. And if you'd be so shocked what we get, but we get requests to do EKGs for cataracts. We get requests for low-risk surgery to get a hemoglobin, an INR, a PTT, a platelet count, and an EKG. This happens all the time. We're still getting those sort of requests. So when it was that type of situation, we wanted to be very prescriptive. The evidence supports not doing these things. But there are situations that we're going to talk about today where the evidence is really unclear and there's honest disagreement. And in those situations, we wanted to allow for physician judgment. And so we give the physician, here are the options. Both are reasonable. What do you think makes sense for your patient at this time? If you think about that, that's very important, particularly when you're talking about enoxaparin and bridging. There are some patients who are on vol and they're the perfect patient to bridge if it's indicated, all right? But other patients, they can't even show up for their appointments in time. There's no way they're going to get that enoxaparin dosing correct. It just doesn't happen. And if you've been doing this job long enough, you know that. And you can actually kind of tell which patients that's going to happen with. And just to give you another example, then I'll turn this over to Alex, how important this prescriptive versus non-prescriptive part is. When it comes to anticoagulation, it turns out, according to physician surveys, 30% of physicians bridge patients who are very, very low risk for thromboembolic events. There is no evidence to support that, and yet they do it. There was an observational trial called Orbit AFib that follows people on AFib, and it turns out about 20% of people get their AFib interrupted. And when they looked at our behavior as physicians, there was no difference in the CHADS-VAS score between those we bridged and those we didn't bridge. So meaning we were not taking any considerations of what the risk was. We just bridged sort of indiscriminately. So these are big problems that our tool tries to address. And with that, I'm going to turn it over to Dr. Campbell, and he's going to specifically talk about preoperative stress testing, antiplatelet management, and finally anticoagulation. Alex? Does this work? All right. Thanks, Mike. This tool was actually born 8 years ago in this very spot, right here. I was a chief resident. It's 2010. Klaus Perrock is in the audience, and I just have to say this at least once. Klaus told me, and I had on the screen 8 years ago, if you don't rattle your cage, you deserve to rot in it. And that was the theme of my grand rounds. But I was given a talk on the 2007 preoperative stress test guidelines, and I was bothered by some of the recommendations, namely the recommendation for patients with poor functional capacity, with risk factors, undergoing intermediate or high-risk surgery. The wording is that we should consider stress testing if it changes management. What does that mean, to change management? I can see if it recommended something that is linked to an intervention which improves outcomes, but just changing management didn't really make sense. So I read the entire 89-page document, convinced that the answer would be in there, and it wasn't. So we threw the guideline away and went to all the primary research. I read everything I could on stress testing and prophylactic revascularization, and at the end of all that, I was shocked. And it was an epiphany, and it changed the way that I viewed consensus guidelines after reading the guidelines and then going to primary literature. It was a very good exercise. I came back to this podium, and my recommendations were pretty simple, or my interpretation was like, we shouldn't really be stressing that many people, if any, prior to surgery, regardless of the risk of surgery. We have no clue what we're doing with beta blockers, other than don't stop them prior to surgery, maybe statins for vascular surgery. And at that time, we didn't know much about aspirin. And that was kind of it. Mike was sitting where Roxanne is right now, met me right here after, and asked me if I wanted to help him develop a tool. As he said, he was interested in reducing unnecessary testing. So I said, sure, I'll help with a tool to help guide clinicians in this process. I thought it might take a week or two. We spent 4 or 5 months reading everything we could perioperative-wise, and we built the tool. And I still have a picture somewhere. I wanted to bring it. I couldn't find it. But in the chief's office, this ugly flow sheet with patient characteristics and if this, just this branching mess of a flow sheet. And we knew that nobody uses these. This is clear in the literature. Nobody uses complicated flow sheets to make decisions. We don't have time, and we don't know where you put them. We don't know what billboards are. So we made an Excel program, which you could just click through, and the Excel program walked through the algorithm, and it hid all the complexity from the clinician. We wanted it to be simple in the front end. This is the lingo's front end, but very complex on the back end. We wanted to shield the clinician from the complexity so they actually use it. We took this to the COC, did a 6-month kind of little trial, did a pre-post analysis, 95% physician utilization. We didn't force anybody to use it. They just wanted to use it because it was simple and it worked and it was easy, saved time. Over that 6-month period, we reduced the cost $70,000 in 6 months in testing in one clinic. If you extrapolate that across Allina in 1 year, a conservative estimate would be about $3 million in unnecessary testing, right? So that was 8 years ago. Fast forward to now, the tool has changed a lot. Not just visually, it's much more beautiful. It's web-based. It's no longer on Excel. But also the mission has changed. The focus has changed. We still focus, obviously, on cost reduction, but have morphed into safety and quality. How did that happen? We had a lot of help. Josh Mueller came on board, and he took this tool and developed the Allina Prep Clinic that was born from this. And Josh was a huge force. We learned a lot. Dave came on, and for years carried this along. And that same process we did again and again and again. I call these stories. We would take areas where the evidence was unclear or where practice was inconsistent or the guidelines were not clear. We'd look at the primary evidence, come up with our recommendations that were reasonable, talk to all different groups. Mike calls us going on a dog and pony show. We would literally do this again and again and again. And at the end of the day, come up with a reasonable consensus, community standard. That's how we did it. And I'd like to tell the story of tell about 3 of these stories, or I call them tales. Again, each time we did this, we had an aha moment.
Wow. What are these recommendations? So I'd like to tell the tale of 3 assumptions. Why assumptions? In the words of Mike, we know less than we think, so we do more than we should. We know less than we think either because we don't know the evidence or the evidence isn't clear, then we make assumptions, and then we do a bunch of stuff that we perhaps should not. So the first story is of preoperative stress testing. Patients with stable coronary disease, increased ischemia on stress test is associated with an increased risk of MI. MI is a common complication of non-cardiac surgery, therefore evaluating for and eliminating ischemia prior to surgery will reduce the risk of perioperative MI. To this date, there's been one high-quality randomized controlled trial published in 2004 in the New England Journal of Medicine. It's the CARP trial. Developed 500 veterans prior to high-risk vascular surgery, open AAAs, STEM-POPs. Most had abnormal stress tests. They found themselves on the cath lab table, and they each had to have at least one severe major epicardial stenosis. At that point, the only exclusions were then severe left main, EF less than 20%, severe aortic stenosis. A third of these patients had severe through vessel disease. Half the group, they revascularized, 60% PCI, 40% CABG. The other half, they removed the catheter, remove the sheath, held pressure, and let them go forward with their high-risk vascular surgery. That's a cool trial. What happened? At about 30 days and 3 years, there was no difference at all. The curves were superimposed. You'd say, well, how is this possible? Why wouldn't fixing a severe stenosis that causes ischemia reduce the risk of MI? Assumptions. We assumed that that was the culprit of the perioperative MI. It turns out when you look at autopsy studies of fatal thrombotic perioperative MI, it's not 70, 80, 90% stenosis that causes it. It's 20, 30, 40% stenoses. You don't see those on stress tests, nor would you revascularize them in the cath lab even if you were there. Second story is of perioperative aspirin. In non-cardiac surgery, patients with an increased vascular risk is associated with an increased risk of MI. Aspirin, by decreasing platelet aggregation, reduces the risk of MI. Therefore, patients with risk factors or established vascular disease will benefit from aspirin in the perioperative realm. To this date, there has been one high-quality randomized controlled trial published in the New England Journal of Medicine in 2014. The POETS-2 trial randomized 10,000 patients with an increased vascular risk to aspirin, low dose, or placebo prior to surgery. 83% of patients had at least 3 risk factors, a third had established vascular disease, and a quarter had established coronary artery disease. So what happened? At 30 days, the risk of death and MI were again identical. The curves are completely superimposable. However, in the aspirin group, the patients had a 20% increased risk of bleeding. And this was major bleeding. This wasn't nosebleeds. Their definition was that you had a major bleed is greater than 4 units of blood transfused, requiring endovascular procedure or coiling or repeat surgery. Right? That's a big deal with no decrease in MI. So again, how could this be? How could aspirin? A third of these patients had vascular disease. We know in the outpatient setting or in the real world that these people benefit from aspirin, but they didn't when we tested it in a trial setting perioperatively. Again, assumptions. We assume that because the majority of non-perioperative MIs are thrombotic due to plaque rupture. Turns out that perioperative, that is a mechanism. However, also MIs are caused by bleeding, incessant tachycardia, fluid shifts, hypertension, hypotension, vasospasm, etc. We wouldn't expect aspirin to benefit that group. And this brings up what Kim Eagle from Michigan called the yin and the yang of perioperative medicine. We have a therapy, aspirin, which will target one mechanism, thrombosis. Yet that same therapy will cause an increase in bleeding, which can also cause MI and actually other problems. Diminishes the benefit. Final story is of bridging, and this one shocked me more than perhaps all the others combined. Not trying to editorialize, but I just don't understand why the current guidelines say what they do. Dave? Well, I can talk about it. If somebody can fix this, that'd be great. Bridging. In patients with atrial fibrillation, patients with atrial fibrillation are at increased risk of stroke. Anticoagulation reduces that risk of stroke. Approximately 250,000 patients in the United States require interruption of anticoagulation for vascular procedures every year. Therefore, bridging will reduce the risk of perioperative stroke. To this date, there's been one high-quality randomized controlled trial. You're sensing a theme. Perfect. Thank you. Published in New England Journal of Medicine, 2015, the BRIDGE trial. BRIDGE trial evaluated 2,000 patients with atrial fibrillation and randomized patients to bridging or no bridging prior to non-cardiac surgery. The great majority of patients were CHADS 2 to 4. What happened? There's no difference at 30 days in the risk of thromboembolic complications. However, in the bridging group, there was a threefold increase in major bleedings. Again, not nosebleed, not nuisance bleeding, real deal bleeds. Again, how could this happen? Why wouldn't bridging work? It should, right? We assume it. Again, assumptions, assumptions, assumptions. We assume that thromboembolism is common and bleeding is uncommon. It's actually not true. In the BRIDGE trials, between 0.3 and 0.4, 0.3 is 0.4% incidence of thromboembolic complications, whereas bleeding, if you didn't bridge, is 5-fold higher. If you did bridge, was 13 times higher, right? So bleeding is very common. The idea that bridging is safe, bridging increases the risk of bleeding by 3 to 4-fold, and this is in a trial setting where you pick the patients perfectly and you bridge perfectly. That does not reflect real-life clinical practice. Finally, this idea that bleeding is benign. There's a really well-done statistical analysis from 1997, almost 20 years ago, where they used observed rates of stroke perioperatively and observed rates of bleeding and calculated a risk-benefit. This is New England Journal. They calculated that for each 10,000 patients we bridged for AFib, you would prevent 2 strokes. You would cause 300 major bleeds, resulting in death or permanent disability of 12 people. All right? Prevent 2 strokes, kill or disable 12. It's akin to plane crashes, in my opinion, versus car crashes. We're terrified of plane crashes. They don't crash very often, but what they do, it's a bad thing. People crash cars all the time. They usually don't die, but across the population, way more people die from car crashes than they do plane crashes, but it's this that we worry about. So I'd like to talk about the elephant in the room. This will come up in discussion, is what do we do about CHADS 5 and 6? These were underrepresented in the BRIDGE trial. Only 3.5% of patients in BRIDGE had a CHADS of 5 or 6. A few things. First of all, BRIDGE is the only randomized data we have, and although they were underrepresented, they were included and there was no difference. Second, no observational study in history has ever shown a benefit of bridging. I'll say that again. There has never been a trial, an association, anything that has shown benefit in bridging. Number 3, CHADS and CHADS-VASc were never intended to stratify perioperative risk of stroke. They were intended to assess an annual risk of stroke for an outpatient, nor have they ever been validated in the perioperative realm. Next, that model from 1997 where they made these assumptions based on the average risk of stroke and average risk of bleeding, they did a subsequent analysis where they doubled the risk of stroke, halved the risk of bleeding. And their recommendations were the same, that there was a net harm in bridging. Finally, there is an ongoing trial, and this surprised me. Again, we're full of surprises every time you go into this stuff. The PARAP2 trial is randomizing patients with mechanical valves, aortic and mitral. Bridge, no bridge, for non-cardiac surgery. Right? We still don't know if bridging works in mechanical mitral valves, and their risk is way higher than CHADS 5 or 6. So we will be studying this. Starting next week, January 16th, every pre-op performed throughout the entire Allina, that's greater than 500 clinicians, will use our tool. With help of MHIF, Steve Bradley, Craig Strauss, we'll be following each of these patients. We'll be looking at the impact on cost, efficiency outcomes, such as OR cancellations, et cetera, length of stay, readmission, 30-day total cost, 30-day mortality, and we'll be looking at bleeding and clotting, right? We have an opportunity to look at this issue. It's not a randomized trial, but our numbers will be so big that we may be able to move the knowledge base downfield. It's fine to disagree. I think we all agree that when you have a STEMI, we should probably revascularize them. The data is pretty clear. In this sense, this is my interpretation of the bridging data. Somebody else might have a different opinion, and that's fine. I would argue we should find out, and I think we will. This has never been performed in the history of medicine, by the way, to apply a decision tool like this and standardize the approach to perioperative medicine. So it should be very exciting. Now for the main event, Dave will teach or show you the tool.
Thanks, Alex. So as we mentioned, the tool, it's quick and intuitive to use, yet underlying it are layers and layers of logic that drive the recommendations to help that PCP at the bedside provide best practice and deliver excellent care. So I'm going to run through a few different scenarios to demonstrate a few aspects of the tool and bring to light some of the topics that Alex was describing. So the tool has several different pages that bunch together different aspects of the preoperative evaluation. First, we need to look at what is the procedural risk of that for that individual, for that surgery. And so let's say we have a 70-year-old fellow who's having a hip replacement, okay? Very common procedure. So we'll select intermediate here. And you can see this page, we're collecting various patient characteristics, say 70, not a lot else from here. Here's our cardiac assessment. This is gathering information to generate recommendations down the line. Say has good exertional capacity. Let's say has a bit of heart failure, compensated. Say EF is down a bit. And let's say the patient has had an MI in the past, a few years ago, and that's what brought their EF down. And so here, this page, obviously, we're collecting different medications, and we're going to recommend what to do with them at the end. Let's say on an ACE, bit of beta blocker, and on aspirin. So here's the heart of the tool. You see how quickly we got to this. Our recommendations page. Now the idea is that the PCP runs this tool and generates this page and then can copy this directly into the H&P, and this page of recommendations then travel with the patient to the anesthesiologist and surgical team. Now, the first thing I'll draw attention to is what we call the CV snapshot, or we sometimes refer to as the Sharkey snapshot. This includes critical cardiovascular information so that the anesthesiologist can very quickly determine what's the big picture on this patient's cardiac status. So you can see they have good exertional capacity. EF is down a bit. History of some heart failure, history of MI. Very quick. As we move down, pre-procedure testing, you can see there's really not a lot of testing recommended. Hemoglobin, potassium, based on EKG. When we look at this, excessive testing or extra testing has never been shown to improve perioperative outcomes. There's randomized data that shows you test more, it doesn't do anything. The only thing that actually improves perioperative outcomes is improved communication, i.e. snapshot, helping communicate to anesthesia and the surgical team. As we come down, you can see medication management recommendations. You can see that we're recommending holding the aspirin for 7 days prior to surgery. This is based on that POISE 2 trial that Alex was just describing. And importantly, so anesthesiologists see these recommendations and they're wondering, really, that's what we should do? We have these references that travel with the patient, travel with this page. And these are thumbnail sketches of what's the data behind the recommendation, what's the reasoning that goes with it. And so it's fine print, I know, but anesthesiologists be able to look at that and be reassured, be confident that what's recommended in the tool is what is a reasonable approach. So I'll run through another scenario now. Let's have maybe a little more complicated patient. Let's say a 75-year-old patient having a small bowel resection, partial small bowel resection. Let's make him a little more complicated. 75, had a TIA a few years ago, bit of diabetes. And let's say that his exertional capacity is poor. Can't walk those blocks. His hypertension, his AFib. And we'll say he has coronary disease, had a stent a couple years ago. But his EF is good. So here we come to a point where we are not prescriptive in our recommendations. Based on the CARP study, other studies, we know that most patients don't benefit from a stress test prior to surgery, from revascularization prior to surgery. But there may be specific circumstances where a stress test is reasonable. And so our tool is flexible. It allows the PCP to use clinical judgment at the point of care and decide what's best in that specific circumstance. I'll say no. All right, so we'll get a couple medications here. Beta blocker. And this patient had AFib, so we'll say that they're on warfarin. And we'll stay on some aspirin too, because of that stent. So here, another situation, uncertainty exists. CHADS of 5. We provide the information for the PCP, again, talking to the patient, working with the patient in the room, decide what's best for them. Are they able to inject Lovenox? Do they want to? How much are they worried about stroke versus bleed? We say, but we do assist the PCP. We say our experts recommend considering individual comorbidities, disutility of treatment, patient preference, but we favor not bridging. Here we're collecting the bleeding risk, one of the other risk factors. And we'll say the surgery's on the 18th. Okay, so back to our recommendations page. You can see how the TV snapshot has changed. We have a history of a stent, AFib in there with controlled rate. Recommendations again. Come down, you'll see that we're actually saying continue aspirin in this situation. Remember, this patient with an old stent who's on aspirin, having an intermediate bleeding risk procedure. There's a post hoc analysis of the POISE-2 in November that suggests that these patients probably derive benefit from continuing. But scrolling down further, we can get to that warfarin recommendation. Last dose to be taken on the 12th. Remember, surgery's on the 18th. Now, we all know to hold warfarin for 5 days before surgery. But if you're like me, I'm always wondering, what does that really mean? Do I start counting on the day of surgery? Do I start the day before? What about when they say take your last dose 6 days before? By the end, I have a calendar that I'm flipping and counting days. And so the tool takes that, I exaggerate obviously, but the tool takes that out of the PCP's hands and takes care of it for him. Computers are very good at calculating. Let's let the computer do the calculation. All right, one more scenario. Let's say this is a low-risk procedure. How about a 75-year-old woman having a lap chole? And let's say she has some CKD. Not too severe, though. She has some hypertension. That was a factor there. Let's say she's had a valve replacement, mitral valve replacement. EF is good, though. And let's see, we'll say she's on a bit of ACE for that CKD, and again on warfarin. I think I said she was 75. So here, we have a mechanical mitral valve on warfarin. We're deciding whether to bridge or not. While there's not data to really drive that decision, there is a consensus that probably bridging these patients makes sense. So we don't hem and haw. We say bridging is recommended. But we still do leave it in the hands of the PCP. I'll bridge. Bleeding risk, this is a cholecystectomy, so we're over on the low end. Now we're going to enter her patient characteristics. Let's say she's obese. Let's say she has some extra weight, 240. CKD isn't too bad though. And again on the 18th. Now, what this is gathering is information for the enoxaparin dosing. Okay, I look at these factors: an obese individual with some CKD, and I have no idea what the best enoxaparin dose is. So we'll see what the calculator says. Come to the recommendations page. Again, laying out all that good information for the anesthesiologist. We come down. So here we have laid out so the anesthesiologist can understand exactly what the thrombotic and bleeding risk factors are. Last dose of warfarin again. Again, enoxaparin 80 milligrams. So if we were doing a straight weight-based dosing, she weighed 240 pounds, so a little over 100 kilos. We'd be doing 100 milligrams per keg twice a day. So we'd be overdosing by a little bit. Last dose of enoxaparin no later than 7 p.m. on the 16th, so 2 days before surgery. If we were doing standard dosing of enoxaparin, we'd be holding that 24 hours, so the morning of the day before surgery. So again, overdosing a little bit, leaving this patient at risk for being partially anticoagulated at the time of surgery. So what all goes into all these calculations? At the core is creatinine clearance. But how do we estimate creatinine clearance? Should we be using creatinine clearance? Maybe we should be using glomerular filtration rate as calculated by the MDRD calculation, the CKD epi. What do we do? Should we use ideal body weight in those calculations? Should we use lean body weight? How do we decide when to stop? Within this, we use the Cockcroft and Galt model, which is the gold standard for medication dosing, things such as enoxaparin. Studies that are developing medications typically use that to validate their recommendations, their dosing recommendations. Within that, though, for most individuals, we use the ideal body weight, but if a person is obese, greater than 30% actual weight above ideal body weight, we adjust that to adjust for body surface area. If a person is particularly thin, we use the actual body weight instead of the ideal body weight. So if the actual body weight is less than the ideal body weight. Separate calculation for getting that dose and the stop date. That's based on the half-life of the medication as determined by that estimated creatinine clearance. So a lot that's going in there. If you take these two simple lines, the tool has worked through an immense amount of logic to help that PCP deliver care. It's helped them decide, do we interrupt the anticoagulation? Do we not? If we're interrupting, do we bridge or don't we? It's helped them calculate when to stop the warfarin, what dose of enoxaparin to use, when to stop the enoxaparin. This is helping them deliver best practice to that patient. So with that, move on to questions and open up for discussion.
Okay, now for questions, make sure that you talk into the mic, okay?
One from all of us. That was absolutely fantastic. Thank you. One question is, this has the potential to be a living document, and what's your process for updating it? Who makes choices about the quality of the data? How is that weighted? These are all problems when it comes to guidelines, or do you do this like an update, and then you accumulate it all and get it all at once and say, here's the new version?
That's a great question, John. We do have sort of a formal structure written how we do that. But so we periodically review the literature, and from reviewing the literature, if there's substantial changes, the four of us look at that evidence, and if there's questions, we go to experts and that type of thing. But it's somewhat similar to up-to-date, if you will, that sort of process. And I kind of was a little nervous, so I missed one of my slides. But we talk about level of evidence and that type of stuff. But the truth is that it is often gray, and it requires subjective determination. So when the evidence is gray, we are giving you options. And when the evidence is pretty clear, then they're binary. And so that philosophy goes with the updates as well. And so, for example, our latest update literally was within the past month when Boys 2 did a subgroup analysis where they said, okay, it turns out maybe you should consider the aspirin if they have stents. And so we know that what we say today may be different than tomorrow. But we do have a formal process written in for reviewing it.
Yeah, thank you. That was a great talk, and thank you for having me part of what you've done. Just a quick thing about the patients with CHADS 5 and 6. I know that I think it's probably appropriate to leave it to the primary care physician because the bridge trial had this probably 3.5% of these patients had CHADS 5 and 6. I've seen it with my colleagues here from vascular that sometimes my colleagues operate on patients with history of stroke, and we look not to bridge, yet they do come back with a stroke because you have to look at the stroke risk versus the bleeding risk of the surgery, and those CHADs 5 and 6, they have 12.5, 18.2 risk of stroke in a year, but not necessarily surgery. And plus, the surgery will add to the risk of stroke, especially if it's a complex vascular surgery with, aortic debranching or whatever. So I like the idea of leaving it to the primary care physician plus the surgeons. I think our surgeons have to probably be part of the decision making for the 5 and 6. Because as you said, there's really no solid data, because only very few of these patients in the bridge trials were really CHADs 5 and 6. So having it to the primary care physician and the surgeon, I think, makes sense. So we are in the process of actually updating our anticoagulation protocols, which I think you guys use most of we're consistent with our procedural anticoagulation recommendations. It's the only difference that we probably going to change to be consistent with yours is the 5 and 6, because we don't have really an evidence for yes or no for bridging is to really involve the surgeons that are going to be really performing the procedure, dealing with the bleeding, and plus having the patient as a important component of the discussion to see, would you think, would you fear more of a stroke, what could be having a debilitating outcomes, or, the surgeons see what the surgeon thinks about, the bleeding risk. I think this is a great tool.
We're not using vascular surgery yet. That's one thing I wanted to say is that this is not for vascular surgery. We thought it was
non-cardiac surgery.
Non-cardiac surgery.
And then we'll be discussing with you guys for the next iteration of that.
Because it gets a lot more complicated.
Yes, it does. Okay, thank you.
This is a fantastic talk. One thing that wasn't clear to me, how do we use this? Now, obviously, I'm not a primary care physician, but once someone's had a transplant, folks won't even do a skin biopsy without us clearing them, which I'm also glad to see you hopefully moving away from that terminology, which is kind of a pet peeve of mine. And I'm also curious what the feedback has been from the anesthesiologists. And then my last question is whether you have any interest in tackling what I call the tyranny of NPO, which is, I think, another perioperative question that often comes up.
Those are all good questions. The NPO is something we've been working on, but it's very difficult to gather consensus on it. Some anesthesiologists are further ahead on that than others. There are also specific circumstances. For example, if they're having a bowel prep, it changes things. So there's different things, but that's one thing we have been working on. As far as anesthesia groups, we've met with a number of anesthesia groups. Anesthesia group here at Abbott, we presented about 2 months ago in this room, and they were very excited, had some very nice feedback and very good questions.
And also from the finalists, we didn't know that going to the closest final anesthesia, which is bleeding. That has implications for bridge.
Yeah, and then we've met with the Mercy Anesthesia Group, and we're meeting with the United Anesthesia Group in the coming weeks. As far as access, so we're targeting PCPs. So within their H&Ps, pre-op H&P templates, there's access to the tool. It is available through web links. We're also working on a more cardiology-specific one for patients undergoing angiograms and other such procedures. So there's probably some tailoring that needs to be done for a lot of the procedures that we work on.
Hi, I'm one of the vascular surgeons for those who don't know me, but I noticed I ran through a couple scenarios and I input one like I had just done a fresh carotid stent for a stroke. And in that scenario, it said hold the Plavix, hold the aspirin, or Coumadin for bypass. Is there probably the easiest way is I noticed for cardiac stents, if it's less than a year, it just flags it and says, please discuss with cardiology. Would there be a way to kind of input, because it's not infrequent that we see somebody after a lap chole who probably didn't need it quite yet, who comes in with cold leg because their bypass shut down or their stents thrombosed. To just kind of put a trigger in there if they're on antiplatelet or anticoagulation for vascular reasons to just discuss with surgeon.
Yeah, so I didn't show one of these examples. We have a limited number of scenarios we could run through, but if you have what we call a fresh stent, so you had a PCI within a year if it's a DES or 6 weeks if it's bare metal stent, it's like do not stop without talking to cardiology. It's red almost, I'd like to have it flashing, but We couldn't get that in there. And so it would be similar to that for those high-risk vascular stents that you're talking about. Right, it's a good point. We'll look at that and take that back to our team.
This is absolute genius, and congratulations, and thank you very much. I'm wondering, well, we'll take the pacemaker situation, where it appears that maybe the best thing to do is not stop the warfarin and not bridge. I think, but of course I'm not data-driven. But I've had some discussions with Chuck Gornick on this. Can you enlighten us on that a little?
Yeah, there's a whole different menu for the cardiovascular stuff, and we just started to look at that, and it varies.
If you bridge with a pacemaker and you put in a pacemaker, it increases the risk of hypothermia versus just continuing work. The issue, we don't use this for pre-angiogram or pre-pacemaker at the time, but we will. Then that will be discussed.
So you raised a really good point that there's so many different potential scenarios that it does become really intimidating. And so what we try to do is just focus on non-vascular and see if we can get that right, and then just slowly add on, because you just, like the things you mentioned, it just gets unbelievably complex. And I guess what our fallback is, I think that whatever we're doing is probably better than what we were doing before, and which was basically pure chaos. And if we're honest, right, it depended on how you felt. So we're just trying to just bring it a little bit closer to the truth, and knowing that what we recommend today may be different tomorrow, and then hopefully we can expand it to your specific examples.
Congratulations on getting to this point. I look forward to working with you guys in the next step, which is evaluation and implementation, which is a whole other hurdle in of itself. When you think about that, one of the things I think about is in terms of things that are helpful in implementation, particularly as you think about moving beyond the walls of Abbott Northwestern and even Allina with this concept, is the strength of the evidence upon which the tool is based. And I worry a little bit about the tension of being guideline-based, which are consensus recommendations that are generally, versus going a level beyond. And I think you should be applauded for doing that, but at the same time, I wonder if you could talk a little bit about where the tool differs specifically from the guidelines in terms of recommendations and how you kind of adjudicate those differences, because I worry about acceptance of a tool that's not based on national standard guidelines versus those things we've developed internally.
We acknowledge that in every scenario for like 5, 6. I personally believe that we should, but we give the option.
So what Alex is saying is we brought the points to your group here that where there is some controversy and where there is some disagreement. And so whenever that's the case, we're upfront with it and say, here's your 2 options. But the truth of the matter is, if you look at this stuff, there is no standard, really, because
guidelines say this, data say this.
But I just to give another point, the guidelines are conflicting, and so.
Well, and I think that's just it, right? So the guidelines are not a rule. I mean, it's the Bill Murray quote from Ghostbusters. It's not a rule; it's more of a guideline. So like we're providing you the best that we can, recognizing that we're only going to be prescriptive. So I think that although you should applaud yourselves for the fact that you're going back to the primary data. At the end of the day, this is guideline based, and I think there's a strength in saying that as opposed to a weakness.
Yeah, so if you have comments, like we have a preamble at the beginning where we try to lay out all the stuff, and so if people have suggestions on how the verbiage should be for our recommendations, or even just the beginning, we're totally open to that. But we've struggled very hard to try to get precise in terms of our language, but we're definitely open to do it better.
We also have an endnotes. We also have an endnote section we didn't bring up, but this, again, those references that we were showing, those thumbnail sketches of the reasoning and the data behind it. There's an entire endnote section that goes through essentially every piece of recommendation that we have in there. It's quite exhaustive.
As far as I'm aware, there's no recommendation where the ACCHA would recommend doing this or considering this, so we say do not. We will say, in this situation, ACCHA recommends this. This is what the data suggests. You make the decision. And there's not very many of those.
I just think that the high-level introduction, you know, there's benefits to things that the guidelines as opposed to lacking by guidelines.
We just do that when we talk.
To some extent, this is similar to what we did with level 1 with respect to looking at best available evidence and saying, well, this is what we're going to do, even though there's some controversy about it. And then the power of that was that at 5 and 10 years thereafter, we were able to look and see at the outcomes and then, you know, acknowledge some of this uncertainty that say, well, we did it this way and this is what happened. And to me, and maybe Steve, you could comment about how we do research on this in real time, because the beauty of this is you'll be able to see what happens to these patients, and then that may change guidelines in the future. The guidelines may be determined by your observation.
So I'm a big fan of pragmatic research, which means that you leverage the real world in which we work in to try and understand the implications of the things that we do. So the ideal is to do what's called a block randomized trial, where you take clinics and you cluster them and you say, you're going to get the tool in January, group 2 is going to get it in March, group 3 is going to get it in July. Problem was, as Allina said, everybody needs to start using this whatever the date was. And so we're left with the pre-post analysis, but you can do some complicated algorithmic or complicated statistical analysis to try and understand, is there an inflection point at which point the tool goes in that you see a large reduction in the use of certain tests, and do you see a trend line that's different than what was prior? So given all the emphasis on choosing wisely and the like, there's probably been a reduction in preoperative testing over the past 5 years or so. But we want to see if it's steeper now that we put in a tool that's prescriptive and guideline directed in terms of what to do, and then at the same time we can look at trends and outcomes. So that's the way you study it.
Guideline directive, I'll use that word forevermore. But I do want to say that the tool is spread organically, for better or for worse, and so in a way some of this has been contaminated because the tool is being used quite a bit right now. Yeah, but I guess my point is I think we started to influence the culture of Allina even 8 years ago, and slowly, organically, I think we're a little bit ahead of the curve compared to other places because of sort of the tool's philosophy sort of extending it. And Dave can tell you how many times it's being used now where we didn't want it to be used, quite frankly.
Yeah, so we have a pilot right now involving ANGMA clinics, and it's supposed to only be accessible through our website, but it turns out folks within the Allina Health Group, our PCPs, are coming in and getting it. So it's been used about 2,000 times in the last 6 weeks. And so that when I first learned that it was being used that many times and obviously being used by the entire health group, I think I might have had a little asystole, but...
Just in terms of the guidelines, since the guidelines came up, the ACCP guidelines, when they talk about bridging for, CHAS 2 of the up to 3, they don't bridge, and 3 and 4, based on the risk and benefits, and 5 and 6, they do recommend bridging, but that was the 2012. When the ACC actually recommendations came by about a month ago, I think I shared it with everybody, the actually 5 and 6 right now, as you guys mentioned, there's really no data to say, yes, you bridge or don't bridge. So I think this is great to look after, when you do your post-implementation, see what the data says. There are some of these recommendations says, you still leave it to the primary care physician. Bridge, you choose bridge or not to choose bridge. Do you think about, involving our clinic for anticoagulation clinic and hemophilia clinic to kind of say, hey, if you need more help with this decision-making, call or speak with the anticoagulation clinic for further recommendation? This is one question or comment. The second thing, the recommendations talk about when to stop Lovenox, but it doesn't say, maybe I missed it, it doesn't say when to resume anticoagulation, because this is a very important piece of information.
That's impossible to tell a month prior to surgery, though. Yeah, it might be complication. We can't say it started 5 days after.
Sure.
So that would be
at least a little glimpse of recommendation, because I've seen it, patients that being on anticoagulation decided to interrupt anticoagulation, but yet nobody really said, well, resume this, but everybody was depending on the other.
We've thought about that, and maybe we'll address it in the future, but it gets really problematic because in the studies, they've had problems, people starting it too early, and there's a lot of judgment. It gets really complex, so we purposely do not address that at this point.
We can talk about the thrombophilic clinic, et cetera, when we work with the vascular team.
How about stating at least wait for 24 hours post-surgery? This is the consensus right now, and then decide with the surgeon, at least a glimpse, but it's up.
A statement like that could be very appropriate.
It is 8 o'clock. Are there any more questions? Thank you, everybody. Please take a moment and thank our sponsors for today, which are Bristol Myers Squibb,